add something like insufficiency, excess, and the irregular intake of nutrients. If someone is having excess nutrients, they are also malnourished, overnutrition. Like someone have not mentioned, if they are obese, according to what Shisha is saying here, someone so someone who has a BMI above 30 who is obese, they are already malnourished. So when we're talking about malnutrition, we're not
because sometimes, when you're guilty, you feel like, because of my BMI, I'm pretty obese. Anytime, if I exceed here, you can't obese. But that BMI was meant for Africans, for Americans, or for all human race. You need to understand.
It is a standard measure for all human
All
race.
human beings
For now. Yes. As per the World Health Organization guidelines.
Oh, okay.
Yes, and we follow there.
Which edition?
2024. Hey. So, Bastin has talked a lot on most of these things. She just wants me to talk about part of the management and why we are much more interested in malnutrition. It is said that Rubanda district contributes 47% of all the malnourished children in the Kabale Regional Referral Hospital, and the Hamugwa specifically sub-county, it has around 28%, with the biggest number coming from Shebeya. Shebeya is also malnutrition. So when we are talking about malnutrition, it's something we should put an emphasis on. And it stays almost every health worker you need with the knowledge. Knowledge is the first equipment we have to manage malnutrition. So, we have basically two forms. We have OTC and ITC, which means OTC is outpatient therapeutic care. For children to be managed under OTC or outpatient therapeutic care, these are children with malnutrition and no underlying complications. Abana abine konka batine bindi bizibu kushanga mwana, they have malnutrition but they don't have anemia, they don't have other infections, they don't have like diarrhea or what. Those children can be managed under OTC. In other words, you can manage a child, Aisha Omereza Rutafa Agaruka Ngahe. Then you assess after 2 weeks, or depending on the time you will give the child, depending on priority, how they are doing. So that is OTC. Managing a patient from home, they come, you assess, take weights, take work, take all those automatic measurements, and look at the progress. There are instances when you find you have done all of that and the child is not gaining. For example, in our setup at Amugwa, there are some of the tests that we may not be able to do. And so, if you have done something of that nature, you have given the child for 1 month, the child was at 5 kilograms, is now still at 5, it means there is something that is not being done. Most likely, the child is not taking Rutafa. Or, we have seen cases where you give a mother, you say give 3 seconds per day. When they reach home, those things, those Rutafa things, they seem to be enjoyable with some members. So other children of the family start enjoying it. And you say, the people have experience, I'm started talking. So now you find in the long run, you find the child is actually taking only 1 second. The other children are sharing them. So you find before you are giving, you are saying, what am I doing? What am I not doing? Boom, the child is actually getting under dose. There are so many factors around before you can think of probably there's something which is medical that you didn't see. There are so many other factors you can ask the mother, you can assess, and you see. So that is children with malnutrition and don't have underlying complications. Whereas children who have malnutrition and they have underlying complications, let's say anemia, let's say they have heart issues, let's say they have diarrhea, they have infections, those children need to be admitted. And what we have said is inpatient therapeutic care. There are 2 things to be managed. You will manage malnutrition and manage what? The cause, the underlying cause for the complication. To Together, are we done? So you manage both the cause and what? The malnutrition. That's why you find some children are being admitted at Kabale Regional Referral for 2 weeks or even more than that, and they are either on F75 or F100, depending on the complication the child has. Actually, even here, we have those therapeutic tools, but I'm very sure that a few of us know that they are there, and a few of us even know how to give them.
Yes.
That is it.
And to eat them.
Eating them, I know people know. Because there's a day I saw someone picking, it is powder. There's people, yes, it's there. People are picking and mixing for their children, not taking home. They know how to eat, but giving for a patient is where the problem is. So, earlier on we had actually programmed with Ruth that they bring those F175. Ruth was a nutritionist. We thought she could be of great help, but finally she's no longer there. So it seems that department is somewhere perhaps. Is it for us?
If we get, we can, if you get a child, I am sure every last year is something.
That is you thinking you are sure, but you may. So I've talked about OTC and ITC. Those are two basic management principles of managing a child with undernutrition. Under what? Then they have overnutrition. I've seen children grow 5 years who are even obese. Not so. Most of them, one, you have to rule out other causes, like for example, you may find the child is even diabetic. You have not seen children grow 5 years who are diabetic? Yeah. You have to rule out those other issues. Then you have to health educate. That is, of course, you educate the child, the mother, on their income. Are we together? Win? Oh, I am alone. So, management includes health education, screening for non-communicable diseases, which are the most risk factors to bring about that overnutrition. And once you do that, you come out to the best diagnosis and you manage the child accordingly. If the child is taking biscuits every day, you talk to the mother, you say, you have to stop this. If they are taking these chapati chips every day, you have to advise the mother that these things actually from what we have come up, this child is actually having overnutrition. So you need to reduce. And you actually, in your health education, you must describe the possible outcomes of a child being obese at the age of below 5 years or even below 10 years. Like some of them including being diabetic. Being obese is a risk factor for being diabetic. Are we together, sisters? Being what? I didn't say you, I meant this other one. But when I say obese, you may think I'm talking about you. I did. Okay. Then the other thing is, you talk to the mother about breastfeeding. Yesterday I interacted with the mother. This mother tells me the child is actually having a mark of 11.7. That is real. Right? So this child, when I asked the mother told me that she breastfeeds the child twice a day. Because the grandmother prefers remaining home with the baby as the other one goes to the baby. So the child breastfeeds early in the morning and the evening when she comes back. So some of these malnutritional cases that we have here are as a result of parent initiated, if I may say. Then the other thing is, you have seen these issues to do with most of us who are maybe mothers who are. You go home, you buy milk, you leave for the maid, give the child, the maid also has a kid, or the maid herself, you have a child with the malnutrition. What is this? These things are happening. They're actually happening.
Especially when you are so
Hey, you are smiling, but these things are happening. There is a woman, she's from around that corner, because she works with some big organization. She came here with a child who was having malnutrition. She works with a big organization. So she told me, she leaves the children with me. She told me, now the children at home, they only want to eat chips and chocolate. She doesn't live with the children. She comes to work only over the weekends. The children remain with me. So you can imagine you are like a CEO over the programs office of JSRC. You have a child with malnutrition. It's not that it is something which you do it intentional, but these things are happening because most of us have neglected the part of our responsibilities because we are looking for money. We are not saying it is not necessary.
It is necessary, but we should not be there if you have paid your maid. Even when you reach home, you have left here to do. Go to the kitchen and prepare for your child. Monitor what your child has eaten. Don't just go in bed and WhatsApp, then you leave everything for a maid. You're paying, but you need to interact.
And next, if you give everything for the maid, you even lay the maid for your husband. And in the long run, you also get malnourished.
You wake up at 8 that you're going to work and have a maid at home. My husband calls them personal assistant. So you say personal assistant, you leave clothes for the child, for the mother, for the husband, and you want this maid to set up for you.
Joseph, to realmente. So the other thing is time appropriate giving of supplementary feeds. For like some children above 6 months, we normally say children should start having the supplementary feeds after 6 months, right? So you find you are not giving them to the child because the demands are going to increase. After 6 months, the demands are going to increase. That's actually where you don't have enough milk to sustain in Uganda, and you have to give maybe cow's milk, you have to give soya, you have to give mkumba, all those things, and you find you are not giving them timely. In the long run, you may actually end up having a child with a malnutrition. So we are saying you must give them timely. You discuss with the maid, or you discuss it with your own heart or your other children. For example, say after every 2 hours, we shall be giving one chikopa chechi champungu. Then the next 2 hours, we give the child soya. The other 2 hours, we give hamura hamura. So, we are also talking, please remember, let's come back. We are also talking about micronutrient supplementation. Micronutrient supplementation, for example, like vitamin A. Government or World Organization has supplemented that with child health days, which is always in the upper right? And October. We are giving those are micronutrients which children need and which we must supplement. So in so doing, we are trying to prevent what? Malnutrition. So when these children come here with diarrhea, we give them zinc. Zinc does not stop diarrhea. Are we together? Here we are supplementing. You know, zinc helps in the fertilization of the cells of the intestine. So we are giving zinc to supplement the intestine. Then we have what we call regular health checkups. You may find a person like a baby is malnourished, but he doesn't know. Because he wakes up in the morning, takes his breakfast, comes to work, goes, takes lunch, but he's eating beans and sweet potatoes. So when they are preparing, the beans are down, sweet potatoes are on top for the week. When they change, the sweet potatoes go down, then the beans get down. So he says he has changed the diet, which is really not changing. So people like Andrew. So you ask when you ask two, a meal which has a sauce and what? And this. Ask him. He may not have, he may not even be able to remember. Check soda, get chapati, and he does. A good day has taken chips. find like please so now you say we are taking chips, chapati. The best thing you add on the soda. Now in the long run, you will find you are adding some of the nutrients. You are taking one like my co-presenter earlier said, something to do with the balance there. When you talked about the goal, the grow, and the grow foods. So you find you are only taking maybe only this thing. And in the long run, you get the malnutrition of either this or this around. Wamchenga kuja mutashanga buli zo Kenya nyama kwasa shamba nyama kushoto kuyabihimba yaoza mutowe bwina bwena. Okay, so ebyo byona okatukutraza kubiga abo byona there are so many and want to go and work for patients. The other thing is one talk about what are the consequences of a child who gets malnourished. The consequences of children who get malnourished. One, they have what we call mental retardation. If you go back, make a research, you will find most of these children who have had malnutrition, especially below the age of 2 years, most of them, they are poor performers in class. And it's to him. So kwa jambo mwana ya bwana mtuku, especially asiye yake hivi, chance yoku children of class is extremely very high. It's extremely very high. We are talking about cognitive development, a poor cognitive development. Shanga mwana mwana tarango. Kushanga magezi kwa mgrasti gari okangano kwa urakuta zeshi. Okwa akushenga Joseph. Bye no good and magezi zeshi. Nago tagi. Like you very well know that someone who is malnourished, most likely their immunity has done what? Oh no. So they are prone to most of these other infections because their immunity is low. Like we said, as Vastina has, the micro-presenter Vastina said, that these grow foods, they are for body protection. So it means your body is no longer what? Protected. So in the long run, if TB comes, if maybe the area comes something very small, you are down. Because already your immune system is very low. Then in the long run, they have very high chances of dying. In other words, increased risk of death. Hey, it is also another complication which happens if most of our things are left unattended to, so they end up doing what? Going to see the road before their time. That's what we assume they go before their time. Obiro tulihamwe. I'm going to ask abantu kurateka teka chini zisibuchasa kubwira nichi. Tarakura. Tutashigambiraho okura na mwete chini bila kama nakura taji. Ano haro classification ezinanga namberi zo nanga. So age malnutrition ejo mbilingo keta. Haro starting kushango mutari mukufa lechite. Alemu Please say promise wise recently. Chama tukaje wote na chigamba kupenda na kwanza mchanganya kwa mfano. So we have not said you are short. We have not said you are short. But you are sister. So we are saying malnutrition is about in 5 forms. Shango mutari alimu we used to call it the dwarfism. Those days of our primary. I want to be short. Remember we talked that where sister was talking about something to do with the height for age. At my age, there is a certain height I'm expected to be on. You may find that I'm just swinging around. I'm even in my national terms of height. So then the other thing is wasting appearance. I mean wasting, yes, wasting. When I to atleta when marasmus on primary. Shanga kona kana kama ile kona kali kata kai kona kazi Oranza kana ukala anza kona esifa still kama with old age Rankamuzee yako rashanga wene maso zona zile. They have what baggy pants. Yes. Kona karanga wene pana kasigezo mutwe ngama kufaga ndibona nachachi. Ranga mara nachachi kwa bona na wana ugaba.
Even face, all the face.
Yeah, you are talking. So when you have what we call underweight. The first one was standing, the next one resting, another one was underweight. You find you have the height is enough, but the weight guns. Are we together, the green sisters? Then we have what we call micronutrient deficiencies. This is something which is common to most of us, almost all of us. You find there are nutrients that your body is actually not having. That's why you see people like Alfred, they say, let's go down to look for chinono. Because he knows chinono has phosphorus, has calcium, but for you, you say, me, I will eat my beans, my greens, my other meat, but you find your body is lacking calcium. All the time you find you have muscle pains, joint pains everywhere. You go to the hospital, they test, they do everything, they say everything is what? Is normal. You just needed that they test electrolytes, they test those minerals, they check potassium, calcium, all those other minerals. When they do those tests, you find you are lacking something like iron, lacking like zinc, lacking like calcium, and it is the only thing which is disturbing. Someone comes to the hospital this week, next week comes, you don't have a diagnosis, another week comes, I have joint pains, I have anything. You do all the tests you can, but you find there is nothing. You find they just have those micro. We have macro and micro. And not macro hardware, but macronutrients and micronutrients. So the biggest deficiency we always have is the micronutrient deficiency. Then the last form of malnutrition is what? Is obesity or overweight. There are 5 forms. We have stunting, we have wasting, we have underweight, we have micronutrient deficiency, and we have overweight or obesity. Obesity, like Bastina described it before, is when you have a BMI above 30 kilograms per meter or something like that. I'm sure the green sisters do not take BMI. Clinton knows how to explain that very well. You know how to take more. Part of the reason you are here is that we mentor you such that when the sister, in case you become a daughter-in-law, you are able to handle her when she comes. Even when you are not a daughter-in-law. Even when you are not a daughter-in-law. She can be a daughter-in-law of the whole clan. So, Clinton, you will take up the month of explaining how to take a BMI for the green sisters. I know Rosalind knows it. So, how do you determine the child is actually, like Bastina said, there is something she missed out. How do you determine the child has malnutrition? We have about like 5 areas you look at. Yeah, there is physical appearance. Physical appearance. You look at the child, you see the distended belly, you look at the silky hair, all those things. You see the wasting and you say, this child has malnutrition. Then you have measurements. How physical appearance, first you look at the child, you really say, this child is malnourished. Even when you have not gone to do any other test, just by mere looking. Thereafter, then you have doing other tests or measurements. You go, do more, do weight, do height, all those things. There you are doing the measurements. Then we also have where we do laboratory tests, like testing for micronutrients. Benja knows. Those electrolytes, you have a deficiency, so you have malnutrition. So those are laboratory tests. You have anemia. Those are laboratory tests. Are we together? Then the other tests where we do serum proteins, serum zinc, all those things. They look at them and they will determine that you have actually malnutrition. Are we together? Are these things like Chubaito? Yes, Clinton.
Thank you so much. I wanted to say something about the forms of malnutrition. I've heard you tell us about things like undernutrition, overweight, obesity. So there's a time where I was at the Kabale Regional Referral Hospital, and I was placed on the pediatric ward. So they had a professor, his name is Professor Tindimwewa Gideon. He actually did gastroenterology. Yes, yes. So he was telling us about something, about how to write the right diagnosis of a child who is undernourished. Because when you look at the word malnutrition, it's like a bucket. It swaps up all like obesity, undernutrition, and overweight, and some other classes, right? So if you get a child who is undernourished, and their problem is that they also have edema, should we make the diagnosis as severe acute malnutrition, or we should write it as maybe severe acute undernutrition, because their problem is having less proteins in the body, other than writing it as some? Because I see most people write some instead of saying severe acute undernutrition, maybe with or without edema. What would be the right thing to write?
That's why I was saying we can preferably put it as PEM, protein energy malnutrition.
Malnutrition.
They are lacking proteins. You've seen children being transfused with what we call albumin. Albumin. You find the only thing the child is lacking is protein. And what they need albumin. They go just buy a pack of albumin, they transfuse the child, and they stabilize. And they start telling them to resolve and give it.
What I'm trying to mean is that, don't you think we are confused to write the word malnutrition on a diagnosis other than being specific, whether it is under or over? You get my point? Because because from the definition, malnutrition is either having less or more. So shouldn't we be specific and say under or over?
Yes,
depending.
Now, that is the best thing. When you are actually when you get these cases, you are supposed to specify severe acute undernutrition or severe acute overnutrition. But when you just say severe acute malnutrition, it does not justify if it is over or under, or if it is protein energy malnutrition. So that's what Clinton is trying to put forward, that at least it should be able to be specific. If they have malnutrition, which malnutrition? Like we described, the malnutrition is having excess or deficiency or irregularity or the nutrients. Promise to recommend.
But according to WHO, they classify in malnutrition, they say normal, in mild, severe malnutrition with no edema and with edema. Maybe that's the thing you're talking of, you can note it in the notes. But according to the Ministry of Health, they classify normal, mild, severe nutrition, some with edema and some without edema. Then when you say that some with edema, we need to see, is it +1, +2, +3, so that when we are giving, we see how the baby is responding. And according to the guidelines, this baby with edema should be weighed every day, because you expect this baby to lose weight.
When we base ourselves on the national guidelines, the WHO does not say undernutrition. But you know those professors, all those doctors, but somewhere they are writing, because what is actually the professor is talking about, he one time also supervised me. He's very strict. He wants if it is under or over, a bit more specific. That you should not be like a villager who just comes and say, so to mambo yako rada organizing malnutrition, you can clinically look at the child, leo mwana ina mutuku, ninga shi okolera laboratory, ninga shi measuring chin, you can take history. Mwana arongoko kuna kuambia kwa mkazi wa nyama zona abuza ya mwana roka kasheshe nachi na mwananzi. So that is historic taking. then umuguze complementary feed zararya ki hata kugambe tunyo mwana turana nyo muhunga kushi ico namwana muhi amashereka namwe yo mu muhungu nothing else. So that is history. If I don't church examine number 12. Then you are also talking, we look around the medical history, the vaccination status. You look about the deworming status. So, I'm trying to be as brief as a cock. So, first thing I'm reaching the scores, these are mostly applied in children below 6 months. You as well know that mark starts from 6 months up to 59 months. I went together, we're not saying 5 years, we're saying 59 what?